Your brain has automated walking so completely that the cerebellum runs it without consulting you. Foot placement, stride length, hip extension timing, arm swing, all computed below conscious awareness, repeated identically 10,000 times a day. Reverse the direction, and every one of those automated computations fails. The cerebellum must rebuild the movement in real time, from scratch, using processing resources it has not been asked to use in years. There is a reason the neural circuits that run forward walking do not run in reverse, and the reason is that no consolidated pattern for backward gait exists in the spinal cord. There is a biomechanical finding showing that reversing the walking direction reduces patellofemoral compressive force by 30 to 40%. One knee, one set of cartilage, a different loading vector, a different outcome. And there is data showing that reverse walking improves forward walking metrics more effectively than additional forward walking practice. All of it comes later. Start with what forward walking actually is at the neural level. Because the automation is the problem. Central pattern generators for locomotion reside in the lumbar spinal cord. Neural circuits capable of producing the rhythmic, alternating flexion and extension pattern of walking without input from the brain. Brain does not command each step. It sets the parameters, speed, direction, terrain adaptation, and the spinal pattern generators execute. Cerebellum coordinates the timing. Basal ganglia manage initiation and termination. Motor cortex intervenes only when the terrain demands conscious adjustment. By adulthood, forward walking is the single most practiced motor pattern in the human repertoire, an estimated 100 million steps per year, every year, for decades. Neural pathways that control forward gait are so heavily myelinated, so deeply consolidated, so thoroughly automated, that walking requires almost no cognitive engagement. This efficiency is the product of motor learning, decades of repetition driving the pattern deeper into subcortical circuits, freeing cortical resources for other tasks. Myelination is measurable. Corticospinal tract fibers serving the locomotor circuits show among the highest myelin densities in the entire nervous system. The insulation that speeds neural transmission has been built up by billions of repetitions to a thickness that makes the signal virtually instantaneous. The basal ganglia circuits that initiate and terminate the walking program are so well consolidated that a person can begin walking, maintain pace, navigate obstacles, and stop, all while holding a conversation, planning dinner, or thinking about nothing at all. The cortex is free because the subcortical systems are running the show. It is also the problem. Cerebellar circuits that compute balance, coordination, and real-time spatial adjustment are barely challenged during automated forward walking. The system that keeps you from falling runs on autopilot, and autopilot does not improve with practice. It coasts. The person who walks 5 kilometers a day on flat pavement is maintaining cardiovascular fitness while providing almost zero novel input to the motor control systems that degrade most with age. The cerebellum, the proprioceptive integration circuits, the prefrontal motor planning regions, all of them are idling during the walk. The heart is working. The brain is not. Think about what that means for the 65-year-old who has been told that daily walking is sufficient exercise for the brain. They are performing the motor equivalent of typing on a keyboard they have used for 40 years. The fingers move. The cortex is disengaged. Forward walking does not challenge the motor control systems that degrade with age. It maintains the minimum. It does not reverse the decline. Now, what happens when the direction reverses? Because every component of the automated gait cycle fails simultaneously, and the cerebellum must rebuild it all in real time. Direction change eliminates the spinal pattern generator's automated output. There is no consolidated pattern for reverse gait. The circuits that have been running forward walking below conscious awareness for 50 years have no template for the reverse direction. The cerebellum must recompute every component of the gait cycle from scratch, not from memory, not from a stored program, but through active computation under novel constraints. Foot placement must be calculated without visual confirmation. Eyes face forward. Feet move backward. The proprioceptive system, muscle spindles, joint receptors, Pacinian corpuscles in the sole, must provide spatial data that vision normally supplies. The cerebellum receives proprioceptive input. It has not been asked to rely on at this resolution since the person was a toddler learning to walk. Hip extension timing reverses. The gluteus maximus, which fires at heel strike in forward walking, must fire at toe off in reverse. Ankle dorsiflexors and plantar flexors reverse their roles in the stance. To swing transition, arm swing timing must reverse to maintain rotational balance of the trunk. Each of these reversals requires active cerebellar computation, pattern generation under novel constraints, with no automated template to fall back on. Computational load is not merely different, it is categorically higher. In automated forward walking, the cerebellum monitors the pattern and makes minor corrections. A slight adjustment for a slope change, a timing modification for a surface transition. In reverse walking, the cerebellum must generate the entire pattern from first principles at every step. Computing foot trajectory, timing muscle activation sequences, integrating proprioceptive feedback in the absence of visual confirmation, managing balance through a center of mass trajectory that the vestibular system has rarely encountered in this configuration. Every step is a novel computation. Every step demands resources that forward walking has not requested in decades. Cerebellar cortical connectivity changes measurably during novel motor tasks. Novel movement patterns increase cerebellar excitability and strengthen the functional link between the cerebellum and the motor cortex. Giacomo Koch and colleagues demonstrated this using transcranial magnetic stimulation. The cerebellum engaged by a novel pattern is physiologically different from the cerebellum running an automated one. It recruits more Purkinje cell circuits, generates more climbing fiber error signals from the inferior olive, and drives more synaptic plasticity in the deep cerebellar nuclei. Climbing fiber error signals are the mechanism by which the cerebellum learns. Each error signal modifies the synaptic weights of the Purkinje cells it reaches, updating the cerebellar model of the movement. Backward movement forces the cerebellum into a learning state rather than an execution state. The distinction matters. An execution state maintains existing patterns at minimal metabolic cost. A learning state builds new patterns at significant metabolic cost. Consuming glucose, recruiting additional neural circuits, generating new synaptic connections. The 65-year-old walking backwards for 10 minutes is running their cerebellum in a mode it has not operated in since they last learned a genuinely novel motor skill, which, for most people, was decades ago. Well, and the biomechanics of the knee change in a way that explains why reverse walking reduces pain that forward walking produces. Forward walking generates ground reaction forces that load the knee in a specific pattern. At heel strike, the tibia decelerates and the quadriceps fires eccentrically, lengthening under load. To control knee flexion under the body's weight, patellofemoral joint, the junction between the kneecap and the femoral groove, experiences peak compressive force during this eccentric loading phase, reaching approximately 3 to 4 times body weight during stair descent and 1.5 to 2 times body weight during level walking. 10,000 steps per day, each one driving the patella into the femoral groove at one angle through one range with one force vector. In reverse walking, the biomechanics invert. Foot contacts the ground with the forefoot or midfoot rather than the heel. Quadriceps fires concentrically, shortening under load, rather than eccentrically during the stance phase. Patellofemoral compressive force drops by approximately 30 to 40% compared to forward walking at equivalent speed. A study published in the Journal of Bodywork and Movement Therapies by Gondalekar and colleagues found that 4 weeks of reverse walking training significantly reduced pain in patients with patellofemoral pain syndrome, a condition affecting a substantial proportion of adults over 50. Mechanism is direct. The movement pattern loads the knee through a different force vector, distributing stress across joint surfaces that forward walking underloads, while reducing peak stress on surfaces that forward walking overloads. You see, the anterior knee pain that many people over 50 associate with walking, the pain that makes stairs difficult and exercise discouraging, may be partly a consequence of loading the patellofemoral joint in one direction through one range, with one force vector, 10,000 times a day for decades. The cartilage nutrition physics applies here directly. Articular cartilage receives nutrients through imbibition, mechanical loading and unloading that pumps synovial fluid through the matrix. Cartilage loaded in a single direction through a single range accumulates damage on the overloaded surface and starves the underloaded surfaces. The patellofemoral joint that has been loaded eccentrically at heel strike for 50 years has cartilage surfaces that have received asymmetric nutrition for 50 years. Reverse the direction, and the load vector changes. Surfaces that were overloaded are relieved. Surfaces that were underloaded receive compression. The pain changes with it, not because reverse walking is therapeutic in the pharmaceutical sense, but because it introduces a loading vector that the forward-only pattern has been denying the joint for decades. The cartilage responds to the mechanical signal it receives. Change the signal, and the cartilage response changes. For the person over 50 who has reduced their walking because of knee pain, who has been told that walking is wearing out their knees, the biomechanical data suggests a different interpretation. The knees may not be worn, they may be directionally overloaded. The pain is not from walking, it is from walking in one direction only. And then, what happens to the sensory system when vision is removed from the path planning equation? Because the proprioceptive demand of reverse walking is the mechanism that explains the balance improvements. Forward walking uses visual proprioceptive integration in a well-practiced ratio. Eyes scan the path ahead, the vestibular system reports head position, proprioceptors report limb position, and the cerebellum integrates the three inputs using a weighting calibrated decades ago. Vision dominates the weighting. Proprioception supplements. The cerebellum barely needs to work at the integration because the visual channel provides most of the spatial data the movement requires. In reverse walking, the visual channel for path planning is eliminated. You cannot see where your feet are going. Cerebellum must increase the weighting on proprioceptive input to compensate for the absent visual data. Proprioceptive demand spikes. Mechanoreceptors in the ankle, knee, and hip joints must provide spatial information at a resolution that forward walking never requires, because forward walking supplements proprioception with vision at every step. Sensation this produces is distinctive, a heightened awareness of the foot's contact with the ground, of ankle angle, of the position of each leg in space relative to the other. People performing reverse walking for the first time report that they can feel their feet in a way they have not felt them during forward walking in years. The sensation is not imagined. It is the conscious registration of proprioceptive signals that the cerebellum has upregulated to compensate for the absent visual channel. The signals were always there. The cerebellum was not listening to them at this gain because vision was doing the work. This forced recalibration of sensory weighting is identical in principle to what vestibular rehabilitation exploits in patients with vestibular damage, deliberately reducing one sensory input to force the brain to upregulate its reliance on the remaining inputs. Reverse walking is a self-administered proprioceptive training protocol. Every step backwards forces the cerebellum to rely more heavily on the sensory channel that degrades most with age, proprioception, and less on the channel that compensates for it, vision. Practical consequence is that reverse walking trains the specific sensory modality that forward walking allows to atrophy. Proprioceptive acuity, the precision with which the nervous system can detect joint position and movement, declines with age through reduced receptor density, slower nerve conduction, and decreased central processing speed. Forward walking does nothing to reverse this decline because forward walking does not demand proprioceptive precision. Vision fills the gap. Reverse walking demands proprioceptive precision because there is no gap filler. The sensory system is forced to perform at a level the movement environment has not required in decades. Result is measurable. Studies on older adults performing reverse walking training show improved single-leg balance test scores within 4 to 6 weeks, even in participants whose forward walking showed no improvement over an equivalent period. The novel direction challenges the integration system. The familiar direction does not. The balance improvement comes from the challenge, not from the walking. Once that result is clear, the logic inverts. The stimulus that maintains balance in aging adults is not walking per se. It is novelty. The cerebellar circuits that compute balance respond to challenge, not to repetition. Forward walking is repetition. Reverse walking is challenge. The distinction predicts the outcome. And here is what the cognitive data shows. Because reverse walking activates brain regions that have nothing to do with locomotion and everything to do with the cognitive decline that aging produces. Forward walking while talking is a standard clinical test of cognitive motor integration in older adults. A landmark finding published in The Lancet by London, Olson, and colleagues established that older adults who stop walking when talking are at significantly elevated fall risk. The motor system is consuming enough cognitive bandwidth that the addition of a second cognitive task overwhelms available resources. Automated walking in aging brains has become less automated. It requires more cortical involvement than it did at 30, leaving less cognitive reserve for concurrent tasks. Implication is sobering. If forward walking, the most automated motor pattern in the repertoire, is consuming measurable cortical resources in a 65-year-old, then the cognitive reserve available for everything else the cortex needs to do during the walk is reduced. Conversation becomes harder while walking. Navigating an unfamiliar route while walking becomes harder. Monitoring traffic while walking becomes harder. Not because the person is cognitively impaired, but because the motor system is claiming bandwidth that used to be free. The automation is partially degraded. The cortex is subsidizing the subcortical circuits that can no longer run the program alone. Reverse walking is inherently a high cognitive demand motor task, even without the addition of conversation. fMRI studies of novel motor pattern execution show increased activation in the dorsolateral prefrontal cortex, the region most associated with working memory and executive function. Premotor cortex activation increases, the region that plans movement sequences. Supplementary motor area activation increases, the region that coordinates bilateral movement and manages internally generated motor sequences. Backward walking is simultaneously a motor task and a cognitive task. The brain is planning each step, monitoring spatial orientation without visual confirmation, suppressing the automated forward pattern that the spinal generators are attempting to impose, and managing the vigilance required by movement without a visible path. The cognitive engagement is not a side effect of the difficulty. It is the mechanism by which the regions that thin with age-related cognitive decline are being forced into activation. Dorsolateral prefrontal cortex loses volume at a measurable rate after 60, approximately 0.5% per year in healthy aging, accelerating in early cognitive decline. This is the region most associated with working memory, executive function, and the capacity to hold and manipulate information in real time. Its thinning correlates with the gradual cognitive changes that aging produces: slower processing, reduced multitasking capacity, difficulty maintaining focus across competing demands. The thinning is not inevitable at the rate aging imposes. Forced activation through motor challenge is one of the few interventions that has been shown to maintain cortical thickness in these regions, not through pharmacology, not through cognitive training alone, but through the dual motor cognitive demand that novel movement patterns impose. Overlap between what reverse walking activates and what aging deactivates is specific. Premotor cortex, the region that plans movement sequences, thins with age and activates during reverse walking. Supplementary motor area, the region that coordinates bilateral movement, thins with age and activates during reverse walking. Dorsolateral prefrontal cortex, the region that manages working memory and executive function, thins with age and activates during reverse walking. The brain regions that the movement demands are the brain regions that aging removes. The intervention targets the deficit through the mechanism of the deficit itself. That overlap, not approximate, not suggestive, but specific to 3 cortical regions that thin measurably with age and activate most during reverse walking, is the finding that stopped me in the cognitive motor literature, because it means 10 minutes of walking backwards is not merely exercise. It is targeted activation of the regions the aging brain is losing through a mechanism that those regions cannot ignore. The measurements confirm it. And here is what 10 minutes of reverse walking produces when measured. Because the effect sizes are larger than the simplicity of the intervention suggests. 8 weeks of reverse walking training, 3 sessions per week, 10 to 20 minutes per session, improved hamstring flexibility by 13% in adults over 60. Finding was published by Terblanche and Milburn at Stellenbosch University. Mechanism is reciprocal inhibition. Backward stepping requires active hip flexor engagement that reflexively lengthens the hip extensors through Sherrington's law of reciprocal innervation. When a muscle on one side of a joint contracts, the nervous system reflexively reduces the tone of the opposing muscle to allow the movement. Reverse walking activates the hip flexors in a pattern that forward walking does not, and the reflexive relaxation of the hamstrings produces a lengthening effect that accumulates with repeated practice. Flexibility that forward stretching takes months to achieve was produced as a side effect of a movement pattern that simultaneously trained balance, proprioception, and cerebellar function. The hamstrings did not know they were being stretched. The nervous system stretched them automatically as a consequence of the reciprocal inhibition the reverse movement pattern demanded. 4 adaptations: flexibility, balance, proprioception, cerebellar recalibration from one 10-minute movement. No other single intervention produces this combination of effects. A systematic review published in the European Journal of Physiotherapy by Balasukumaran and colleagues in 2019 found that retro-walking, the clinical term, consistently improved balance, gait speed, and functional mobility in older adults across 12 controlled trials. Effect sizes were moderate to large, not marginal improvements, detectable only in statistical analysis, but changes visible in the functional capacity of the participants. Several studies found that reverse walking improved forward walking metrics, stride length, gait speed, and gait symmetry, more effectively than additional forward walking practice. That last finding deserves emphasis. Walking backwards made people better at walking forwards. The novel motor challenge recalibrated the entire locomotor system, not just the reverse pattern. The cerebellar recalibration, the updated timing models, the sharpened proprioceptive weighting, the strengthened cortical cerebellar connectivity, carried over into the forward gait because both directions use the same underlying integration system. Improving the integration system through reverse challenge improved its output in both directions. The challenge improved the system. The repetition did not. More forward walking would have reinforced the existing pattern without upgrading the circuitry. Reverse walking upgraded the circuitry, and the forward pattern improved as a consequence. Yang and colleagues, published in the Journal of Physical Therapy Science, found that 30 minutes of reverse treadmill walking 3 times per week for 4 weeks produced significant improvements in Bird Balance Scale scores. In stroke rehabilitation patients, a population with severe cerebellar and motor cortex disruption, the intervention forced neural reorganization in the circuits most damaged by stroke. The cerebellum, confronted with a pattern it had never stored, built a new one, using whatever neural resources remained after the stroke had destroyed the old ones. Now, the stroke rehabilitation data. Because it establishes something important about the floor of the intervention, stroke finding establishes a floor for the intervention. Stroke patients have lost neural tissue, neurons dead, connections severed, processing capacity permanently reduced. If reverse walking can force measurable functional improvement in a brain with structural damage, the mechanism is robust enough to work in brains that are merely understimulated. The Purkinje cells are still there in the 65-year-old cerebellum, fewer than at 30, with simpler dendritic arbors, but present and functional. The machinery for motor learning has not been dismantled. It has been idling. Backward movement puts it back to work. One more consideration. Because the obvious objection to walking backwards is the inability to see what is behind you, and the objection is valid. Safest protocols for older adults use controlled environments. A clear hallway at home, a track with visible lane markings, a treadmill at low speed with handrails available but not gripped. The treadmill provides the movement while eliminating the obstacle hazard, and the handrails provide security without eliminating the balance challenge if the hands hover rather than grip. Beginning speed at approximately 50% of comfortable forward walking pace, slow enough that the proprioceptive system can process the novel spatial demands without being overwhelmed. 2 to 3 minutes per session initially, increasing by 1 to 2 minutes per week as the cerebellar adaptation progresses. For those with significant balance concerns, supported reverse stepping in place, holding a kitchen counter, stepping backward 1 foot at a time with controlled weight transfer, provides the cerebellar challenge without the fall risk of translational movement. The automated forward pattern is still disrupted. The proprioceptive demand is still elevated. The motor cortex is still engaged. The spatial translation is removed, but the neural computation that produces the benefit is present. Well, and the adaptation curve reveals something about where the benefit concentrates. Adaptation curve is steep at the start. First sessions produce the greatest proprioceptive challenge. The cerebellum is building the pattern from nothing, generating maximal error signals, driving the most significant synaptic reorganization. The person walking backwards for the first time feels unstable, uncertain, hyper-aware of every foot placement in a way that forward walking has not produced in decades. The instability is the signal. The uncertainty is the cerebellum receiving input it does not yet have a model for. The hyper-awareness is the prefrontal cortex engaging with a motor task that the subcortical systems cannot handle alone. By the second week, the instability decreases, not because the challenge has been removed, but because the cerebellum has begun building its model. Error signals reduce as the pattern consolidates. Purkinje cell circuits that were being recruited ad hoc begin forming reliable connections. The movement starts to feel less foreign. By 4 to 6 weeks, balance scores improve. Forward gait symmetry improves. The cerebellum has built a new program where none existed, and the process of building it strengthened every system involved in the construction. Improvement trajectory is important to understand. The greatest neural benefit occurs in the earliest sessions, when the error signals are largest and the synaptic reorganization is most intense. The person who finds the first session difficult and awkward is experiencing the session that produces the most cerebellar adaptation. You see, the difficulty is not a sign that the intervention is inappropriate. It is the intervention working at maximum intensity. Comparison to forward walking is instructive. 10 minutes of forward walking at comfortable pace burns a modest number of calories, maintains a baseline level of cardiovascular function, and provides almost zero novel input to the motor control, proprioceptive, or cognitive systems. The cerebellum idles. The prefrontal cortex idles. The proprioceptive system runs at minimum resolution because vision is doing the spatial work. 10 minutes of reverse walking at half the speed burns fewer calories but forces the cerebellum into a learning state, activates the dorsolateral prefrontal cortex, demands proprioceptive resolution that forward walking never requires, reduces patellofemoral load, lengthens the hamstrings through reciprocal inhibition, and improves forward gait metrics as a downstream consequence of the system upgrade. The cardiovascular benefit is smaller. Every other benefit is larger. 10 minutes of reverse walking produces measurable increases in cerebellar excitability, proprioceptive accuracy, hamstring flexibility, and forward gait symmetry. Improvements are detectable within 4 weeks. Cognitive regions activated. Dorsolateral prefrontal cortex, premotor cortex, supplementary motor area are the regions that thin measurably in age-related cognitive decline. Intervention requires no equipment, no prescription, and no skill beyond the willingness to walk in the direction the brain has not automated. Every 10-minute session produces a cascade of neural events that forward walking does not trigger. Climbing fiber error signals, updating Purkinje cell, synaptic weights, prefrontal cortex activation, maintaining working memory and spatial planning under novel demands, proprioceptive circuits operating at resolution levels. They have not been asked to maintain in decades. Reciprocal inhibition, lengthening muscles that forward walking never stretches, and patellofemoral load vectors shifting to surfaces that forward walking never loads. The cascade runs for the duration of the session, and the synaptic changes it produces persist beyond the session, each one incrementally strengthening the circuits that the next session will challenge again. Cerebellum contains half of all the neurons in the brain. It has been coasting for decades. 10 minutes in the wrong direction is enough to make it work again.